Uh, okay, so now I'm going to start streaming. Okay, I think we are live. Hello and welcome everyone to this interesting radiology case discussion. What we're going to do today is uh, share a few interesting cases, and these will help you prepare for your radiology review exams, be it your American boards, your Indian MD and DNP exams, or be it your FRCR exams for the UK. If you have any issues with the audio or video during the presentation, let us know in the comments and we'll try to sort it out. Today we have Dr. Amaya Kulkarni with us, who is a staff radiologist at Juravinsky Hospital, McMaster University Canada. He'll be sharing 5 cases, and followed by that, I'll share 5 interesting cases, and we'll see how it goes. If you like this format, we can do this again. So without wasting any further time, I shall move on to the presentation. Amaya, can you start sharing your screen, please?
Yes, perfect. Well, hello, everyone. I'll start with my few cases here. So, Amar, I think it says that host has disabled participant screen sharing. Maybe you'll have to change the
Okay,
limit to
so
host or something.
okay, so I have made you host. So I think you'll
Okay,
now be able to share.
correct. Okay, so I hope everyone is able to see my screen now. Let me check that.
Yeah, I see your screen. So all those who are watching us live, just drop in a comment from where you're watching us from. And if you have any issues with the audio or video, do let us know.
Okay, so I'll start with my cases here. I have just compiled about 5 interesting cases with different scenarios. There is no specific system distribution or specific areas which we are going to focus. We are going to look at most of the cases which are a combination of things which you might run across. And I have tried to compile at least one teaching point per case. So without any further delay, let's start with the first case here. So my first case is going to be, okay, sorry, I'm really sorry. Okay, so this is the first case here. I have put together some actual images of the thorax. This particular examination was performed for a screening breast MRI for a woman who is a part of high-risk screening program. So these women get annual screening MRI examinations as a part of our high-risk screening because they are predisposed to higher risk of developing breast cancer. And this was the first baseline MRI examination. So in this particular MRI examination, what you're seeing, I'm going to describe the findings and then let you speak away your answers in the comment section. So this is an actual T2 weighted imaging. So as you can see, there is lots of noise here because this examination is not optimized for the area which we are looking at right now. This was a breast MRI. So in this actual T2 image, you can see that there is a paraspinal mass towards the right. It almost has like a lobulated kind of smooth appearance. Then this was the part of dynamic post-contrast examination. This is the first minute phase. So if you know, and if you're aware in breast MRI, we do a pre followed by 5 post-contrast imaging series, which is at every like each minute. And that is how you calculate your time intensity curves. So this is the first minute post-contrast image. You see that this particular mass, which you see on T2, does not show a lot of enhanced. I mean, there's nothing happening here. But as you go through the phases, this is the third post-contrast phase, so it will be a third minute. So you start to see this heterogeneous enhancement within this particular mass. So after seeing this, we raised a few possibilities. I'm going to ask you to start typing your options, which you think might be an explanation for this particular appearance. But then on the same time, we recommend that the patient should get a dedicated spine MRI examination. So we performed spine MRI. These are the images of dedicated spine MRI. You see this coronal T2 weighted image. There is a heterogeneous T2 weighted lesion here in the right paraspinal location. And this is the actual post-contrast MRI image in T1 weighted phase with fat suppression. And you see all of that enhancement. So does anyone want to type in their answers to say what they think this particular abnormality will be? So you can just use the comment section on YouTube to type in your answers. Okay, so for some reason I'm not able to see anything in the comment section there. But anyways, this basically turned out to
So
be
there is, Amar, usually there
yeah.
is like a couple of seconds, at least 30-second lag. So people are typing in their answers. We have
Oh,
a
okay.
couple of answers already. We have Ayush who says it could be a schwannoma. Stuti says, is it a nerve sheath tumor? And Dr. Ruby suggests that this could be a neuroblastoma.
Okay, that's really perfect. So Amar, if it's okay with you, because I'm not able to see the comments here on my my YouTube channel. So if it's okay with you, will you be able to read the comments to me for the next case as well?
Sure, I can do that.
All right, thanks, Amar. So yeah, that those are really good differentials and really good points that you pointed out. So schwannoma. So moving back to first question, first diagnosis here, schwannoma, which indeed it turned out to be. There are a few pointers for a schwannoma in this case. So if anyone knows, this particular appearance on T2-weighted imaging has a name to it. It's a sign, and the sign here is called as a target sign. So there are so many areas in body where you can have target signs. You can see target signs on ultrasound in liver. You can see target sign on gadolinium enhanced MRI in brain. So this particular appearance is specific to a T2 weighted imaging where you see this peripheral rind of a high T2 signal, and the central portion is usually heterogeneously hypointense. This is quite specific to schwannomas. Depending on where these schwannomas arise, you can have other signs called a split fat sign, then a fascicular sign. So essentially, all of them are dependent on the relationship of schwannoma to the surrounding soft tissues, and the fact that schwannomas they don't invade the surrounding tissue, they just displace the surrounding tissues. So these are tumors of peripheral nerves, and they can occur anywhere on the course of peripheral nerves, but this is probably a more common site. They can be seen in hereditary conditions such as neurofibromatosis 2. Cystic and fatty degenerations can be seen with these kinds of tumors. So this case points to a teaching point here that even if your organ of interest is somewhere else, you have to look at all the corners, look at all the sequences that you have so that you don't miss an incidental lesions like this particular schwannoma. So this was just an incidental pickup and something to remember in terms of differential diagnosis for target sign. Then let's go to a second case here. This case is again interesting. So I'm sure you must have this similar practice in your hospital. So whenever somebody comes with new flank pain, back pain, hematuria, the ultrasound doesn't show any obstructive cause, and they want to exclude any nephrolithiasis or any other urolithiasis which might be causing the patient these pain. So this particular gentleman here, kind of 60 years old, they performed a CT of the abdomen and pelvis without contrast because the symptoms were pointing towards a urolithiasis. So there was no obstructive uropathy, no hydronephrosis, hydroureter. There were no stones anywhere along the course of ureters or in the bladder. But what we did find was that if you pay close attention, even if it's an unenhanced examination, you will start to appreciate that there is a change in contour. There is a bulging appearance to the undersurface of the liver capsule on the right lobe. And this is a coronal reformatted image here. And on this particular image, we start to see the same bulging appearance to this particular capsule. So this points towards an important point here that even if it's an unenhanced exam, you may find an incidental finding like this, which may not appear quite evident, but it just picked up as change in contour or something which just looks abnormal than what it should be. So this particular finding, which we saw on CT, we suggested that this patient should get further imaging. So at that particular time, the patient's renal function tests were within kind of slightly higher and elevated. So they decided to go against performing a contrast CT and start with an ultrasound, just given the superficial location of this particular abnormality, because the index of suspicion was kind of really low as the patient did not have cirrhotic liver. And the other finding was that we thought that just looking at that the abnormality is so isodense to the liver, we thought that maybe it's just a contour abnormality or hypertrophic renal lobe or something like that. So that's why, given the poor renal functions, we started with ultrasound and we were in for a surprise. So on ultrasound, you can see a mass there. I will let you have a look at the mass, see what it looks like on ultrasound, and then you can type your differentials, what you think this particular mass can be. And remember, just a healthy individual walking into ER with just features suggestive of obstructive uropathy or some renal stones, and this was just an incidental finding. So you can type your differentials. What do you think this mass can be? Is it something on the lines of a malignant or benign spectrum. Then in malignant, what you think might be the explanation for this appearance. And if it's benign, then what other possibilities which you think that they could be causing this particular appearance.
I think if you refresh your screen, you'll be able to see the comments, because most of the times the feed is not live. So try refreshing your screen and I think the comments will show up. So Ayush is saying, could this be an FNH? Dr. Lynn, I'm sorry if I'm pronouncing your name wrong. So Dr. Lin suggests, is it an adenoma? Avijit says, is it an FNH? So FNH and adenoma, so those are the common differentials that people are thinking about.
Correct. That's a really good list of differentials. So whenever you see such kind of an appearance, so this particular lesion, if you pay close attention, it is echogenic compared to the surrounding liver parenchyma. So whenever you see echogenic lesions, there are n number of things which can come into your mind. And you should start with the benign spectrum and then move towards the malignant spectrum. In terms of benign, the usual differentials on ultrasound will be, as you said, it can be FNH, it can be adenoma, it can be hemangiomas, focal fatty change, or other mesenchymal tumors like angiomyolipomas, which can have fatty components within it. But in terms of the malignant spectrum, you should always remember that it can be a lesion which is mimicking something which looks like benign, but it can be a colorectal carcinoma metastases or a treated met from breast carcinoma. Then there can be metastases from RCC, thyroid, melanoma. So basically any tumor which can be hypervascular may have this echogenic kind of appearance on ultrasound. And it is really important that you recommend the right next step to ensure that you have evaluated the abnormality correctly. So in this particular examination, we gave a bunch of differentials. We did not basically, we were not able to further characterize this based on this imaging. And the next right step to go forward is to perform a multi-phase liver imaging, ideally with MR, but sometimes it may or may not be feasible depending on the resources which you have. So in this particular case, it ended up being a multi-phase contrast CT. And this is the contrast CT appearance. So this is the post-contrast image, coronal reformat in the arterial phase. And does anyone want to say what it is now? Okay, so I think I'm able to look at the comments now.
Oh, that's excellent.
Mm-mm. Okay, so this particular appearance, I'm really sorry. I don't know what is happening to my my app today. Probably it's crashed or something. So anyway, so this particular, okay, yeah. So I see it now. So yeah, most of you have diagnosed it correctly. This is a hemangioma. So again, this is something which I always tell anyone who is reading ultrasounds in a cancer hospital. When you know that your population is probably going to have cancer, whenever you see a new echogenic lesion in the liver, always try to give your differentials. You cannot be 100% certain that this is benign or malignant, but always include your differentials, that it could be these things on benign spectrum and these things on the malignant spectrum. I have seen a couple of cases when a new echogenic lesion was labeled as hemangiomas. It grew on the follow-up ultrasound and it was a colorectal carcinoma metastases. So something which is really important to remember when you're dealing with echogenic liver lesions. But always remember, hemangioma is probably going to be the most common of those entities, but always remember to give your differentials. Then this is an interesting case. So before I start scrolling through the images, I'll give you a brief history. This is a kind of late 50s or kind of early 50s to late 40s kind of an individual, male patient presented with generalized weakness and some abdominal distension. So the ultrasound was performed. Ultrasound showed an abdominal mass, and that is why they wanted to perform a CT of the abdomen to look for what is happening in there. So as you can see, I'll start with these particular images here. So this is the axial post-contrast CT. I'll just scroll through the images. This is the lower aspect of the chest. You can start to see all of that pleural effusion and a large mass in the lower mediastinum. And then as we scroll down, you will definitely see more abnormalities. So I'm just scrolling down now. So the upper abdomen looks quite okay. And as we go down in the infrarenal aorta kind of its region, you start to see this large margin, which is playing the IVC and aorta, encasing the aorta. Even the renal artery is completely encased, but not completely obstructed. And then as you go down, there's nothing really significant happening in the pelvis. So yeah, so you see large mediastinal and pelvic lymphadenopathy, sorry, not pelvic, retroperitoneal lymphadenopathy in a mid 40s to kind of early 50s male patient. So what do you think would be your differential? So let me get you the findings which are most significant here. So what do you think are your differentials in this case? Okay, that is really great, Ayush. Lymphoma versus testicular mass. Excellent thought. So yeah, I mean, this is really amazing. I mean, you have basically spot on. So this is basically what you should think when you see a new retroperitoneal mass in a kind of mid 40s, early 50s kind of an individual. That's the time when you will probably get presentation of testicular tumors presenting as metastases, the most common being seminoma. They usually have association with cryptorchidism or undescended testicles. Association with microlithiasis has been quite controversial, but there are multiple papers which talk about their association. So in about 25% of patients who have seminomas, they will present as retroperitoneal nodal disease as the first presenting symptom. And usually it's lethargy and some weird abdominal symptoms. It's like all B kind of symptoms. And then on imaging, you will find these large lymph nodes. What is more important here is that the primary testicular masses may or may not be that large to cause all of these lymphadenopathy. Like in this particular individual, the primary testicular mass was really small. It was just about less than a centimeter in size, but it's usually homogeneous, hypoechoic to the testicular parenchyma, and it usually does not go outside of the tunica. So the other closest differential in this particular case is lymphoma, because as you can see on these images, there is not a lot of necrosis. It's all quite homogeneous. It's plastic, surrounds the vessels, displaces the vessels. Again, the same thing is happening in the mediastinum. So lymphoma is the closest differential in this particular case, and probably that's something which I would put first and second, probably the testicular mets. But this person responded beautifully to chemotherapy and is doing pretty well in this particular case. So just something to remember in terms of age and demographics, which can point you towards the right direction in differential diagnosis. So let's move on to the next case, which is case number 4. Again, an important finding worth remembering. So I'll give you a brief history. This patient presented with a history of neck trauma, and they were trying to rule out if there were any occult fractures or some abnormalities to explain the point tenderness. That was the only piece of history which was provided to us in this particular individual. So this particular study, I'll go through the axials here. So this is a soft tissue window of the lower neck, and this is the only area which I have selected because this particular image has a finding. So I'm just going to keep on scrolling till anyone picks up what was the finding. And so basically what happened in this particular case was there was no history of no evidence of acute trauma, no fractures, subluxations or dislocations, no hematomas or nothing really going on in terms of trauma. But there was an incidental finding, and this particular finding is centered in the right supraclavicular fossa. So if anyone can pick up what is happening there, I'll go to the next particular slide, which shows that where was the finding. So you can see that there is a big lymph node in the right supraclavicular fossa. So in an individual where we don't have any history and we find this particular large lymph node, we start to wonder what is happening. What does this patient have as a background? So this is again coronary format, an actual image of the same abnormality. You can definitely see that there is a right supraclavicular fossa lymph node. So then we started looking for an explanation as to why does this patient have this supraclavicular lymph node. When we were reviewing the history, it was found out that this patient has a history of follicular lymphoma and has been on remission for the past 3 or 4 years without any imaging performed. And the imaging before that did not show any supraclavicular lymphadenopathy. So this was new compared to about 4 years ago. So just looking at this particular finding, we recommended this patient to get a staging examination because this was a new lymph node, and the patient presented to the emerge and they performed all the blood work and it looked like the patient was not doing well. So when we performed a complete staging examination, you had disease everywhere. So just look at the spleen, massive enlargement, again new, and then look at all the para-aortic and retroperitoneal lymphadenopathy, which you can see in this particular image on coronary format. So we were basically just seeing the tip of the iceberg, that there was a lymph node which was enlarged in the neck on a CT, which was performed for trauma to rule out neck abnormalities, to rule out traumatic involvement. And then we saw this as an incidental finding. So what is the teaching point here? Always look at all the corners of the film. Even if you have a very limited history, you may find something which is going to change the patient's management entirely, and the patient may benefit from your incidental finding. So just going back to our previous case, there is a question here in the comment section. What about incidence of cannonball metastases? So cannonball mets can be seen in specifically any kind of solid tumor. But if you look at the lymphatic distribution, so the testicular lymphatics, they will usually go in the retroperitoneum and up to the level of renal vessels. So you will see most of the initial presentation with METs will be centered around there, in the retroperitoneum, around the region of renal vessels or up to the level of renal vessels. They can go beyond that, like as you see in this particular case, they can go into the into the mediastinum. Then inguinal lymphadenopathy is not usually common because, as you're aware, the distribution of lymphatics which can drain into into the inguinal nodes, it's usually the superficial skin, the scrotum, penile region, all of that region drains to the inguinal nodes. So whenever you see inguinal nodes in a patient with testicular mass, you should start suspecting that probably the mass has eroded the tunica and trying to involve the scrotum, and that is why probably the disease is spreading into the inguinal nodes. In terms of solid organ involvement, you can see solid organ involvement. It's somewhere, I think, up to 5 or 7%, if I'm not entirely wrong, but you can see solid organ involvement, and that is when you start to see all these mets in lungs, liver. You can see anywhere they can go to central nervous system. But remember, the first site or the first checkpoint where the testicular tumors will like to go is para-aortic lymph nodes to the level of renal vessels. So I hope that explains that particular point there. So the next case, the last one, I have kept it to be a quite interesting one, something which is going to be a slightly difficult one. So this is a 50-year-old female. So this female came here for an outside referral because an MRI of the abdomen was performed to evaluate an incidentally detected pancreatic mass on ultrasound examination. So as you can see, I have tried to label the images and just select the key images here. This is a T2 weighted image, T2 weighted fat suppressed image. Then the two images at the bottom are post-contrast. The one on the left is arterial phase and the one on the right is venous phase. So if you can see, I'll try to describe the mass a little bit here. It's a multi-cystic kind of appearance. It has multiple thin septations. None of these findings suppress on the fat suppressed image. And there is a delayed kind of enhancement of those septae, which we see here. So what happened on this MRI was that we gave a bunch of differential. I'm going to ask you to write your differentials in the comment section, and then I will show you what happened to the patient next. So a multicystic or cystic mass, then on the post-contrast phase, it can show, this one is showing a delayed kind of enhancement. So you can type in your responses. Okay, so I've started to see a few here: serous cystadenoma, okay, mucinous. So yeah, I mean, basically that's what we were thinking, and this was reviewed at a multidisciplinary hepatobiliary rounds, which we host every Thursday, because even they were not sure what is happening and why this patient has this new particular lesion. So we gave a few differentials in this particular case, and something which is really important to remember is when you see this clustered cystic or multiple cystic appearance, serous cystadenoma is going to be the first on your differential. And the fibrous septations can show delayed enhancement in serous cystadenomas. That is something which is a hallmark. The other closest differentials would be an IPMN, but then you will perform your MRCP images to see if you can definitely see any communication. Again, that's not a prerequisite, but if you can see, that is going to clinch a diagnosis of IPMN. And yeah, so somebody has written IPM, and that is really good. The other differential, which are not really common, but something to remember, is solid pseudopapillary tumors. They can also have almost similar kind of appearance. So anyways, we gave our differentials, discussed this case, and recommended that this patient needs some kind of cross-sectional follow-up in the next few months to decide if this thing is growing. Because the patient's physician who recommended this patient to be reviewed on the rounds wanted this tumor to be out. But then it was decided if this is one of these not causing any duct dilatation and not causing any symptoms, then a watchful approach might be a good idea. So then the only problem was that on follow-up CT, the mass grew twice in size as compared to what it was before. And then it was then it was decided that this particular lesion has to come out. Before we go into that, I'm going to show you one actual image and try to see if somebody wants to include something else on the differential. So this is just the topmost slice of the MRI abdomen. You see the lower chest here, and just looking at this image, do you want to include anything else on your differential? So you may have to think about what normal structures are missing here that may silicone implant rupture. Okay, so I mean, the implant was intact, but there's something else which is missing in this particular image. So if you pay close attention, the patient has bilateral implants, but on the right side, you can see the glandular tissue. On the left side, you don't see the glandular tissue. So the patient has probably undergone a left mastectomy in the past, and the implants are probably just to balance it out. So now that's something which got us thinking that why did she have a left-sided mastectomy, and what does it have to do? So that's something which we started to look for. And the final pathology is going to be interesting on this one. But again, this is something to bring to your attention that reviewing all images is really important. In this particular case, we then started thinking, okay, is it breast carcinoma, which can cause metastases, as some of you have pointed out in the comment section? That's really a great thought. So remember that pancreas is not a common site for metastases, but you may see metastases in pancreas once in a while. Like I have seen mets from melanoma, mets from lung carcinomas, and breast cancer to land in the peripancreatic region or within the pancreas in periampullary region or within the head. And that's usually the more common site than the tail and body. And this is something which is really important to look at image and then derive your conclusion. So you saw that the left breast tissue is absent, so probably mastectomy, and then you start to include more differentials. So anyways, we thought that this is probably something which is happening, and then we started reviewing the final breast pathology, why the patient underwent mastectomy. So it was for a malignant phylloides tumor, and the surgeons resected this mass, and it turned out to be a phylloides metastases into pancreas. So that's pretty rare, but just something to remember that pancreas is not a common site, but you can have all of these tumors to go there. Again, RCCs can metastasize, and that's why you should include an arterial phase when you are performing these surveillance CTs on patients who have had previous nephrectomies, because that is the only time you're going to see hypervascular metastases in the pancreas. But just something to remember, adding your differentials when you see when you see multiple findings, some of them may be a history of prior surgery, and just something which will increase the list of your differentials. So I guess those were my cases, and then I'm going to hand it over to Amar. I'm going to stop my screen share here.
Thanks, Amir. Those were wonderful cases. And it's nice to see these routine radiology cases rather than we see these typical cases, and I'm going to show those typical Aunt Minnie cases. So it's always good to see the thought process which we'll have while discussing routine radiology cases. And I especially like the fact that for a couple of images you had scrolling image sets. So that's really useful to learn from a learner perspective. So I'll start sharing my screen. I have 5 cases. And okay, so I think Amar, you'll have to make me host again. So for some reason, instead of making you co-host, I made you the host. So if you can just make me the host. Okay, perfect. So let's sharing the screen. Okay. So I hope you guys see my screen. Do you guys see the case?
Yes.
Okay, I think I may have to check. I am not able to see the comments. So, okay. So in the meanwhile, you guys can attempt this case in the comments section. So this was a young patient, around 40-year-old, who presented with knee pain. This is a frontal radiograph of the knee. And you can let me know your thoughts in the comments. So what is your favorite diagnosis? Okay, so I see that you guys are able to see the case, which is good. Let me just, so chronic osteomyelitis, that's a good thought. So what we see here is an area of sclerosis. I'll just start my pointer. So what we see here, okay, just give me 1 second. So we see an area of sclerosis involving the proximal tibia, and there is a central lucency. So in a younger patient with knee pain with typical history of night pain, which is relieved by NSAIDs, what would be your thought? So Ruby has rightly pointed out that could this be an osteoid osteoma? So I have the CT and MR axial images for you guys. So again, what we see here is a central nidus, and there's significant sclerosis associated with it. On the CT image, there's cortical thickening, maybe there's some slight periosteal reaction. And on the MR, all we see is edema, which is disproportionate to the size of the lesion. So in a young patient with night pain, the first differential with a small central nidus will be that of an osteoid osteoma, as all of you have rightly pointed out. So this patient went on to, so if you see this case, what treatment would you recommend? Would you like to involve any of your other colleagues in your department? So an osteoid osteoma, what's non-invasive, minimally invasive, I would not call that it's a non-invasive treatment, but what minimally invasive treatment would you suggest for these patients? So in osteoid osteomas, the recommended treatment now is RFAs, and most of these patients respond really well to RFA. So this patient underwent an RFA and she had good symptomatic relief. So this was a typical case of an osteoid osteoma. The differential for this includes another important sign that is associated with osteoid osteoma, but usually not required for diagnosis, is something that can be seen on bone scans. So what imaging sign is associated with osteoid osteoma on bone scans? So RFA, so all of you have rightly pointed out that RFA is the treatment. So the imaging sign associated with osteoid osteomas on bone scan is the double density sign. You'll see 2 densities, a central hyperdensity and a density surrounding it, which is known as the double density sign. A differential in that case would be osteomyelitis or osteoblastomas, but osteoblastomas usually are larger than 1.5 to 2 centimeters. So they're not usually an issue with differentials. And the other differential is Brody's abscess. That can often mimic an osteoid-osteoma, but in bone scan, that'll show a central area of reduced uptake due to avascular purulent material as compared to osteoid-osteoma, which will have more of a bright uptake. Okay, before we move on to our next case, I'd like to thank all our members. We have around 40 members in our YouTube community. And for the channel, we have reached 6,560 subscribers, which is quite a feat. And I would like to thank each of you for subscribing to the channel. For those who are not subscribed, I leave a link in the description. And if you would wish to join the membership and support our channel, I leave a link to that as well. Okay. So this is an MR in a patient, an elderly patient who presented with knee pain. No history of trauma, just severe knee pain. So this is a coronal fluid sensitive sequence. Let me know what are your thoughts. Most of my cases are MSK. I'm doing an MSK rotation along with my body rotation. So I think four of my cases are MSK. So it's kind of a mixed bag. Okay, I was expecting this answer, and I'm glad that somebody has called it a song. And I assume by that you mean to say that it's a spontaneous osteonecrosis of the knee. So this is the reason that I wanted to show this case. Earlier, this pathology was known as spontaneous osteonecrosis of the knee. Before that, I'll just describe the findings for those who have not able to pick up. So you see this small linear sclerotic area, and there's significant edema associated with the medial condyle. So this is a subchondral insufficiency fracture. Earlier, this was known as a Sonk lesion or a spontaneous osteonecrosis. But recently, the Society of Orthopedic Imaging has changed this to a subchondral insufficiency fracture, because this is the better term that describes this finding. So this patient did not have significant cartilage damage. All she had was this small subchondral insufficiency fracture, which was causing her severe pain. So if you see this, think about subchondral insufficiency fractures and avoid using the term Sonk. So the preferred term is subchondral insufficiency fracture. These can predispose patients to osteonecrosis, and especially if the lesion is more than 4 millimeter in thickness or 14 millimeter in length. So if you see a large fracture fragment, that predisposes the patient to secondary osteonecrosis. So make sure that you measure this fracture fragment if you get a case. These are always associated, almost always associated with a meniscal tear. And the treatment in this case is depends on the age of the patient, their physical status, and in younger patients who are fit, limited weight bearing is the suggested treatment. So this was a case of subchondral insufficiency fracture. Another interesting point that I wanted you guys to revise about is insufficiency fractures and stress fractures are used interchangeably, but that's not the case. So stress fracture is the larger subgroup. So the stress fracture is any fracture that occurs due to an imbalance between the bone strength and the bone forces. The stress fractures can be further subdivided into two types. They can be insufficiency fractures or fatigue fractures. So insufficiency fractures, just the name is self-explanatory. So these, in these cases, the bone is insufficient. So the bone is weak. So insufficiency fractures are seen in patients with weak bone, but normal stress on the bone. So in elderly patients with osteoporosis, that is the typical age group where you'll see insufficiency fractures. Fatigue fractures, on the other hand, just think about, again, just the name is self-explanatory. The bone gets fatigued by the amount of stress. So normal bone with excessive stress, that can give rise to fatigue fractures. Both of them are called as stress fractures, but remember which one is associated with a weak bone. And if you just look at the name, it's simple. So insufficiency fractures are associated with weak bones, whereas fatigue fractures are associated with overuse. So this is an ultrasound for a young patient in the region. She had abdominal pain, which was long-standing. This is a transverse section at the level of the lower abdomen. So we have this hypoechoic lesion. Does anybody have any thoughts on just the ultrasound? I have an MR image to follow, so I think that would be more helpful. But just on the ultrasound, what does this appearance make you think of? Like, what are the differentials would you think of? So Rahila says that the stress fracture bone is normal, insufficiency bone is abnormal. I had this similar misconception earlier, but remember that stress fracture is the larger subgroup. So fatigue fracture, the bone is normal and excessive stress. Insufficiency fracture, bone is abnormal and normal stress. So excellent differentials by everyone: desmoid tumor, epidermal inclusion cyst, endometriosis. This appearance, Ayush says that this could be a pseudotestis appearance, which is typical of an epidermoid cyst. The only thing that goes against an epidermoid cyst is that if you see the lesion, I know it may be difficult to identify just in limited still actual ultrasound images, but this is slightly deeper. So this is the muscle compartment. So if you see, this is the rectus sheath, and this is in the rectus sheath and not in the subcutaneous soft tissue. So epidermoid cyst would not be a differential in this case, although this appearance is very typical of that. So that's a good thought. Let's see the MR image, and I think it'll be MR image would be more helpful. So one history that I didn't tell you before was this patient has cyclical abdominal pain. So the history is kind of a giveaway here. So if you see cyclical abdominal pain in a young patient, start thinking about endometriosis. So if you see this image on this fat saturated image on the right, you see there is some T1 hyperintensity, although it's not as high as you would want it to be, but this subtle T1 hyperintensity on a fat saturated image suggests that this is hemorrhage, and this was a case of a rectus sheath endometriosis. So these are common locations for endometriosis. The most common ones obviously are the ovaries. You'll see these bilateral cystic lesion, and this imaging appearance is fairly typical for endometriosis anywhere. So you'll see these low-level internal echoes, and on the peripheral aspects of these lesions, you may see these echogenic foci. And these are very typical for endometriosis, and they're thought to be products of repeated hemorrhage and debris, but they have been very specifically described for endometriosis. So if you see this appearance in a slightly young patient, cyclical pain, endometriosis would be a differential. In patients with cesarean scars, we have seen endometrial deposits, so that's another location. Bilateral hydrosalpinx with hemorrhage is a very specific sign, again, for endometriosis. We've done a detailed lecture on endometriosis, and I'll leave a link for those who are interested in the top right corner. Move on to another MSK case, and it's a similar pathology to what we saw earlier. So this, again, an elderly patient, just back pain, no significant history of trauma. We have axial MR, say T1 and fat fluid sensitive sequences. What would be your differential for this case? We have around 36 people who are watching us live. Thank you all. And even for those who are watching us later, if you're not subscribed, make sure you hit the subscribe button and turn on notifications. So the next time we have a video, a live session, you don't miss it. And for everyone who's watching, make sure that you give us feedback. If you like the video, make sure you hit the thumbs up button. If you have any comments on how we can improve these, you can let us know in the comment section, and we'll try to work on all your suggestions. Perfect. So all of you have pointed it out right. Dr. Diaz mentions that could this be sacroiliitis? That's a good thought. But if you see, the pathology is centered more on the medial aspects of the sacrum rather than the joint. So the joint per se appears okay. The iliac aspect is pristine. So in a joint pathology, we would expect changes on either side of the joint, but that's a good thought for sure. The diagnosis in this case is sacral insufficiency fractures. Again, normal stress on a weak bone gives rise to insufficiency fractures. These fractures are very common in elderlies, and you'll see them even on your routine CTs. If you're reporting, you'll see these vertically oriented fractures involving the sacrum. Often they're associated with sclerosis, and in the acute presentation, they can cause significant pain. This also has a appearance which is typically described on bone scan. Does anybody know what is the imaging appearance of sacral insufficiency fractures on bone scan? So on bone scan, the appearance has been described as the Honda sign. So I'll try to just get my pen here. So the appearance simulates that of the automobile manufacturer Honda, their logo. So that is known as, it's not a very sensitive sign. You see it in 20 to 40%, but it's a very specific sign. So Honda sign is associated with bilateral insufficiency fractures. So yeah, Dr. Ruby has rightly pointed out, and yeah, all of you. So that's great. So Honda sign is associated with sacral insufficiency fractures. Moving on to my last case. So this patient had a fall, elderly patient with fall. What are your thoughts? The finding may be difficult to see on small mobile screens. So if you have a difficulty, I'll point out the abnormality. So I'll give you a couple of minutes. So the most common thing you have to look out for are distal radius fractures. We don't see a lot going on the frontal projection, but there's something on the lateral projection. I'll point it out, and maybe it'll be more clear then. So what do you think is happening here? Perfect. So this is a dorsal avulsion fracture of the triquetrum, which is also known as a pooping duck sign. This is commonly seen in patients with fallen outstretched hand. If there are no other associated fractures, these usually heal. They don't require aggressive management. Another differential would be an os triquetrum, but that's not that common, and you won't have that typical history in those patients. So this was this. We looked at this. Oh, we got happy that this is a pooping duck. This is a dorsal triquetral fracture. But another important thing that we have to notice is that this radial shadow is not really smooth. So you'd see there's a very subtle cortical irregularity here. So we suggested, okay, we talked about the triquetral fracture, but we did not comment anything specific on the dorsal, the radius part. So we suggested, okay, if the patient continues to have symptoms, we should do a follow-up. So this is the follow-up radiograph, and you see there is the distal radius fracture is seen better here. So always in patients with trauma and wrist radiographs, it's always, if the patient has symptoms, it's always a good idea to do a follow-up radiographs, because initial radiographs can often be negative. And this is very important in cases of sacral scaphoid fractures, because they can eventually cause osteonecrosis. For those who are not able to see the pooping duck, I have this image. So this appearance, this is thought to be the duck, and this small avulsed fragment is thought to be the poop of the duck. So that's how the pooping duck sign is named. And again, make sure that if you see one finding, and if you see the follow-up radiograph, the triquetral fracture is not appreciated much, and it's probably healed, but this is the fracture that's concerning. On the frontal projection, it's difficult to appreciate, but it's definitely seen on the lateral projection. So make sure that if you see one finding, you don't ignore the other findings on the film. So those were my cases, and thank you all for watching. And if you have any kind of feedback, if you like more of these sessions, let us know in the comments, and I will see you guys in the next one. And thank you, Amar, for your awesome session, and hopefully we'll have you we'll have more sessions from you. Thank you.
Thank you. Have a good day, everyone.